Good day. Today, we will consider the importance of transpulmonary pressure and its main areas of application. Respirators with the PLUX function has a balloon catheter fitting on the front panel. The information about types of the catheter and how they have to be inserted and positioned, you can see in the other video. The transpulmonary pressure represents the lung distension pressure. This is an important parameter of respiratory mechanics, which allows to increase the level of safety and efficiency of mechanical ventilation. PTP measurement allows to separate the lung compliance from the chest wall compliance. Using transpulmonary pressure, the clinician can resolve two different problems: to prevent collapse of alveoli and atelecta trauma. The second task, to prevent ventilator-induced lung injury due to over-distension of alveoli. The peak inspiratory PTP is correlated directly with the probability of lung injury. Why does the patient need PEEP? Positive inspiratory pressure is the pressure at the end of each exhalation created by the ventilator to ensure that alveoli do not tend to collapse. This recruits the closed alveoli in the sick lung and improves oxygenation. However, too high a PEEP level can lead to lung barotraumas. Positive inspiratory pressure is an important part of the lung protective strategy. Do we always get PEEP equal to PEEP which we set? The answer to this question, no. For example, we set PEEP 10 centimeters of water. The intrapleural pressure is different in these two cases, but PTP is also different. So using a tool such as PTP makes ventilation setting more accurate. Why do we use the esophageal pressure monitoring? For individualization of parameters of mechanical ventilation for each patient. It is the main goal. Why can we use esophageal pressure instead of intrapleural pressure? Let's remember where is the measuring balloon placed. In the lower third of the esophagus. It doesn't matter if you use a catheter with one balloon or two. Please pay your attention on this picture and the formula. We are interested only in transpulmonary pressure. It is a pressure difference between alveolar pressure and intrapleural pressure. But we can't measure them. You can see the formula of transpulmonary pressure. There is the evidence that esophageal pressure is a good analog for pleural pressure. And alveolar pressure is assumed to be conditionally equal to airway pressure. So, transpulmonary pressure might be calculated as the difference between airway pressure and esophageal pressure. How can you interpret PTP? PTP has to be always positive. This keeps the lung expanded. If transpulmonary pressure is equal 0, as occurs during a pneumothorax, the lung will collapse due to elastic recall of the lung parenchyma. Where we'll consider different cases. Picture A shows the inspiration for a patient with normal lung function who is breathing spontaneously. The alveolar pressure is 0, and the pleural pressure is negative, minus 8 centimeters of water, creating a PTP of plus 8 centimeters of water. Picture B shows the same lung for the patient who undergoes general anesthesia and positive pressure ventilation with the using of the same tidal volume as the picture A. The lung will be similarly stretched with the alveolar pressure of 9 centimeters of water and pleural pressure of 1. for a transpulmonary pressure of plus 8 centimeters of water. You can see here two cases. Picture B is the same picture from the previous slide. Picture E shows the lung mechanics of the patient with marked respiratory distress on non-invasive ventilation. Although the airway pressure is only 10 centimeters of water, the transpulmonary pressure is very high, plus 25 centimeters of water. In such cases, there may be large negative swings in pleural pressure. Picture B is for a comparison. Picture C shows the inspiration in a patient who has a very stiff chest wall. For example, with severe obesity, massive ascites, pregnancy. Although the alveolar pressure is very high, 30 centimeters of water, transpulmonary pressure is normal, plus 5. Because intrapleural pressure is also high, 25 centimeters of water. The next two slides show how to set PEEP step by step. You only have to answer two questions. Is end expiratory pressure positive and not less than 2 millibar? And is end expiratory PTP inspiratory greater than 20 millibar? Step 1. Is end expiratory PTP exp positive and not less than 2 millibar? You have two variants of answer. If yes, you can go to the next step. If no, increase PEEP by 2 millibar, assess PTP exp, and gradually increase PEEP until PTP exp reaches target range. Step 2. Is end expiratory PTP greater than 20 millibar? You have two variants of answer. If no, check the situation regularly. If yes, reduce tidal volume and P inspiratory, assess an inspiratory PTP, and try to reach the end inspiratory PTP target range. You can see a PTP inspiratory here on the screen of ventilator, and PTP expiratory here. The titration of PEEP by PTP leads to higher PEEP level than set by clinicians in usual practice. We can set the lower PEEP without measuring of PTP, but it may increase the risk of atelectasis. Here, some more situations where PTP monitoring can be useful. Monitoring of parenchymal lung stress, limiting peak and expiratory transpulmonary pressure, monitoring for ventilator synchrony, and the recruitment efficiency. You can see links about the application points of PTP. It's necessary to know that esophageal pressure value depends on many factors. There are different types of lung injury, body habitus, and pulmonary mechanics. For example, in these cases, incorrect position of the balloon catheter, elevation of intra-abdominal pressure, obesity, pregnancy, position-related lung volume changes, etc. Thank you for your attention.